Some people get very confused about what all that means, and they think that if there is no gold standard, prospective randomized double-blind trial looking at the effects of something, that there is no data. Hi, this is Dr. Alan Lifton from Brainsplained. I wanted to talk today about knowing things, how we know things and what we know, evidence and expertise, because I wanted to make some videos about vitamins, but it's awkward because it's also an area where there are some unknowns. And when there are some unknowns, we have a methodology for knowing what to do, which is that we rely on expertise. I had told a patient one time that I thought he should take Bacopa. Bacopa Manieri is a nutritional supplement. It's a herb, and he called up and said, "I'm not taking that. There's no evidence that that helps," which is super intriguing and which is also factually incorrect. So let me talk about what evidence is and what types of evidence we have and how our doctor language works. Anecdotal evidence is evidence that somebody said something. John said this happened. That's anecdotal evidence. Anecdotal evidence is not useless, and sometimes anecdotal evidence is sufficient for us to be very certain about something, and you don't need any more. If that evidence is so powerful that it is convincing, then based on that alone, based on just some stories, something can become the standard of care. We all now know. Here are things that have only that, only anecdotal evidence. Removing a knife that is stuck in someone's chest may cause them to live. Patient comes into the emergency room, he's got a knife stuck in his chest, somebody stuck it in there, the EMTs brought him in, and the surgeons recommend, "We think we ought to take this knife out of your chest. We're going to explore the cavity where the knife is, we're going to try to control the bleeding, we're going to cauterize anything that's bleeding. If we see large vessels, we're going to re-anastomose them," which is reattach the ends. "We're going to give you antibiotics and maybe you will live." We have anecdotal evidence. We've had other cases where that has happened, where the patient has lived and we've been able to remove a knife from their chest. And if we leave it, we know that you will die. Can't leave a knife in your chest. You can't survive it. It's a lethal wound. Have there been randomized prospective controlled trials? No. No trials. Have there been cohort studies? No, nothing. There have been no studies. There's no research that has been done other than anecdotal evidence, because it's really powerful anecdotal evidence. We know this to be true. In fact, even if you're not a physician and you have no training in medicine, you automatically know, yeah, that sounds right. I think it's just so logical. That has to be the case. We also have epidemiological studies. Epidemiological studies are when we notice things. This is a level a little bit higher than anecdotal because it involves statistical associations and analyzing math. People will look at information. They'll gather information. This is not one person telling one story of something. This is not a bunch of people telling a story. These are people who are scientists gathering information on things called cohorts, which are large groups of people, and the cohorts are somehow different. So an epidemiological study looks at, these people who have lung cancer and are smokers and these people who are non-smokers, and what is the incidence. And then estimate the percent chance of getting lung cancer if you are a smoker versus a non-smoker. And then they give you wildly different risk factors for those things, and that's an epidemiologic study. And what that is also pretty powerful information because it's using mathematical rules about the chances that something is or isn't connected. These sorts of information are slightly flawed. These sorts of information don't include causal proof. And then we get into a lot of trouble that things that are associated are not always causal, and the concept for that is that the association between smoking and lung cancer is almost identical to the association between carrying a cigarette lighter in your pocket and lung cancer. We know it's not the cigarette lighters, but the association, the math, will look the same, and so the math can trick you. And then there are prospective but unblinded studies, and They are not always considered the gold standard. Again, sometimes that information is incredibly powerful. It depends also a lot on my outcome measures, what I'm deciding that I'm going to look at. If I have a very objective, undeniable, clear-cut outcome measure, and it's a very significant effect, a prospective open trial, it means I know who got treated and who did not get treated. That may be very compelling. When people are using something like gene therapies where we're reintroducing a missing gene into a disease and you get outcomes that are just unbelievable, that data is super, super compelling. The purpose of being blinded becomes almost a moot point. And then the scientific gold standard is a prospective randomized double-blind trial where I don't know what's going on. I don't know who got, if I'm the researcher, I don't know who got the investigational treatment and who did not. If it's a surgical procedure, there's a sham procedure, and then we do an analysis on the difference between the two groups to prevent me from being biased in the way I analyze the results, if the results could be subject to that. Some people get very confused about what all that means, and they think that if there is no gold standard, prospective randomized double-blind trial looking at the effects of something, that there is no data. And the absurdity of that is amazing. That doesn't mean no data. That means no prospective double-blind randomized trials. If there were no data, if there were no useful data, if we couldn't know things without that, then we would not know that removing knives saves your life, potentially. Although you could still go to surgery and die. It's a critical situation. But we know that's your best chance. And we have 0 prospective double-blind randomized trials. And in fact, you couldn't do the trial. It would be considered unethical because we know that it's not right to just leave it there and watch. There are no double-blind prospective randomized trials looking at whether peyote causes hallucinations. Not needed. No one's going to do that trial. We know it does. And the evidence is what's called anecdotal. We don't even have a cohort study. The only way we know is people said so. When a person does research, the first thing they do is they become familiar with the literature, and then they know the literature. Knowing the literature, when a research person says, I know the literature, that means that they have read every article that has ever been published on that topic, and they have memorized it. They know all the data, they can recite it by heart, and they have an understanding of what was wrong with the methodology of the trial, how that trial was criticized, how it fits in with everything else, and how to interpret the results of that trial in the setting of other trials that might have been contradictory. That's called knowing the literature. And those researchers, when you say something, they'll say, well, I know that literature. And when they say, I'm familiar with that literature, they're pretty close to that. They're just a little wee bit off. This doesn't mean I read 5 hours or 10 hours. We're talking about thousands of hours of studying. And when they do research is after you know the literature, you design a trial, you know the methodology of conducting the trial, and then you execute it. That's doing research. This is important because now those words are not used in the same way. Now patients do research, which means they read, 5, 10 hours, 20 hours of not literature, not primary articles, but reviews that were written by people trying to explain it to a layperson. So when a patient comes to me, and on Bacopa Manieri, I'm familiar with the literature, okay? Which, if I say I'm familiar with the literature, it means I've read maybe 30, 40 articles on that, maybe 50, I don't know. I have a folder on it, and I've read most of those articles, or many of them more than one time. And so I know something about that herb, and I have some level of expertise. I don't think that the patient who said there's no data on that did the same kind of work before he decided that I don't know what I'm talking about. When it comes to that whole arena of herbal supplements and vitamins, There's a lot of problems in that field. However, having said that, there is stuff we know. I mentioned peyote. We know about that. And we know about cocoa leaves, which is the stuff cocaine gets made out of. And people chew on that when they live in the places it grows, and they say it gives them energy, which makes a lot of sense. I believe it. But randomized prospective control trials have not been done. But my level of certainty that chewing on those leaves gives you energy is about 100%. It's probably equal to my level of certainty about the knife removal, and it has the same type of data. At some point, unfortunately, we have to rely on expertise. We have to trust somebody that somebody knows, or else we have to go and actually do the work. But when we go and actually do the work, we have to do the real work, not reading a summary that somebody wrote from, I don't know where he got his data, but like he read it on the Mayo Clinic site that said there's no data or something. We know that chemicals have an effect on you. It's the underpinnings of the entire pharmaceutical industry. We know that morphine has an effect on you. We know that Valium has an effect on you. We know that all the drugs that we give you have an effect on you, and we know that plants are drugs. It's ludicrous to think that plants do not have an effect on you, because you can't say chemicals have an effect on you and then simultaneously say chemicals don't have an effect on you, because those are contradictory statements. And it's not the case that only the chemicals that the pharmaceutical industry has are effective. It's just that those are the only ones, or usually are the only ones, in which prospective double-blind trials were done, because those are very expensive. And nobody's going to do that on turmeric or on bacopa or on cinnamon. It's not going to get done. It is occasionally, rarely done. It's been done with glutathione in Parkinson's disease. If you're taking glutathione for Parkinson's disease, it doesn't work. The trial's been done, and it's been done at a very high dose. So we know that. We know that one doesn't work, despite the theory that it should work. So sometimes it's done and sometimes we know, but it's rare. So most of the time we're dealing with anecdotal evidence. In that situation, we're using understanding of biochemistry. We're looking at some of the chemicals contained in the plant and knowing how those chemicals affect people. We can estimate the dose that you're getting and see if it's going to be effective, and then we can make an assessment about whether or not it makes sense. Bacopa, I'm obsessing on that, but there's many other issues. But bacopa has been studied in an unblinded, prospective way, looking at the AVLT as an outcome, showing improvements. And to me, that's an incredibly significant effect on helping you with thinking. And it's a potent acetylcholinesterase inhibitor. And we know that acetylcholinesterase inhibitors are effective in helping thinking. We use the class as a general class of drugs. There are 3 prescription medications that are acetylcholinesterase inhibitors that are used in dementia. It's very illogical to think that an acetylcholinesterase inhibitor helps you think, but an acetylcholinesterase inhibitor that's in a plant doesn't help you think. That's a slight logic problem. Anyway, I wanted to talk about how we know what we know before I talk about how and why I use vitamins, because almost all the time that data is going to be anecdotal data, it's going to be biochemical data, and almost zero of it has that incredibly high level of certainty that we get from a prospective randomized double-blind trial. And I have another thing to say. Because I understand the mechanism of action, because I understand a little bit about physiology, because I understand a tiny bit about biochemistry, I might think I know something, but you might not. You might not know. And the body is catastrophically surprising. Here's a super simple thing that I think we all know. We all know that it's good to have blood flow. Blood flow is good. And we all know that it's bad to have lack of blood flow. Lack of blood flow is bad and blood flow is good, because the blood brings oxygen and nutrients to the tissue, and without it you have lack of blood, called ischemia, and maybe you have death. When arteries are blocked, there's a lack of blood flow, and sometimes we bypass them. So we bypass the blockage. It's done in the heart all the time, coronary artery bypass grafting, and maybe this will help. And that logic is very solid. We used to do an EC-IC bypass. It was a bypass of the internal carotid artery when there was a complete occlusion. When the artery is completely blocked, you can't open it because you can't find a lumen. You can't find the opening to get to. The whole thing is just solid, and you don't know where to try to cut out plaque. So once it's 100% blocked, you're done. You can't open it anymore, and you have a blocked carotid artery. Each carotid artery is responsible for about 30% of the blood flow. So we said, hey, we'll bypass it. We'll take another artery, the external carotid, and attach it to the internal carotid, and we'll restore the blood flow. Brilliant idea. It's great. Now we have blood flow. And we studied that. In a randomized prospective double-blind fashion, people were assigned to have a bypass or not to have a bypass. And the group who had the bypass did worse outcomes. So it's exactly opposite to logic. That should not have happened. It was very disturbing. Something is missing in our understanding of the physiology of something as simple as blood flow is good. Later on, after a while, we were able to do some fancier tests, and we could find out who had a thing called misery perfusion because we had PET scans. PET scans are where we give you radioactive dye, and the radioactive dye lights up your brain when you're using glucose. And in some people with a significant carotid artery stenosis who have inadequate collateral supply, so not enough blood flow is coming from the other side, they get a thing called misery perfusion. So we can actually measure lack of blood flow. There's not enough blood going into that side of the brain, and it's not lighting up properly on the PET scan. There's not enough glucose metabolism. This tissue is lacking blood, and it's only some, not all, of the people with a carotid artery occlusion. So you can block your carotid artery, and a lot of the people have a complete blockage, but that side of the brain is still, getting enough blood. Or in some cases, it's not getting enough blood. So people said, that EC-IC bypass has to work. There's no way it doesn't work. It probably didn't work because we bypassed a lot of people who actually didn't need a bypass because they actually had enough blood flow from the other side. And bypassing all of those people diluted the results and made us not get statistical significance. We should only do the bypasses for the people who have misery perfusion. So we redid the study again, and we did it only in people with misery perfusion, and it didn't work. The outcome was worse for the surgical group than the non-surgical group. And there's not a good explanation for that. It should work, but it didn't work. And this is a story that's important, okay? And it should teach us all, because this story proves that even with something we think is relatively simple, and we're pretty sure we understand the mechanisms, we may not know. And so when I get something like a plant that has an acetylcholinesterase inhibitor in it, and I say to my colleagues, I'm going to use this acetylcholinesterase inhibitor, maybe it's going to help thinking. They're like, yeah, we don't know. You have to try it out. You have to do a randomized placebo-controlled trial if you want to be sure, if you want to be really sure, because this is very different than when you're talking about the kind of knowledge that's anecdotal from things like we took a knife out of a chest or peyote makes you have hallucinations. So that makes that field a little bit complicated. Anyway, having said that, I do take a lot of vitamins and I would like to talk about them. This covers all the information about knowing and what we know about them and what we don't know. Not all of it. But anyway, it's a brief introduction to that. And I hope that's been brain-splained, and I will see you next Friday.